Hi, everyone. Welcome. It's cool to see how much bigger this becomes every year. I'm Devin Steenkamp from BU and Boston Medical Center. If they're in the not NYU, I'm not going to say the same thing again. If the New York PIs want to come up and take a seat, and here's a microphone for you. I'm going to try to come sit with you. So what we're going to do, hi Ruth, is we're going to get a flavor of what makes New York City and New York State, with Ruth here as well, unique. And this is pretty cool to have these esteemed colleagues of ours up here to answer some questions that I've posed to them. And so it's a powerhouse team here, and I'm going to let them talk. I'm going to interject, ask a couple of hopefully interesting questions, and let them tell us what makes New York and New York State and New York City special. It's a real variety of different expertise and patient populations here, from Manhattan into the Bronx and up into the Syracuse area. So we've got some time. If you've got anything that you really want to ask, just flag me down, and we'll include the questions. Depends on how much time we have and how much talking we have. But we have a fair amount of time, I think till 8:55. So this is fun. This is what about collaborations from. And I think this group is really a really good example of how collaboration works in a single city. I know in Boston, we're the only site. And I'm a little bit jealous when I get to hear about how they collaborate and how they work together. And I wish we were a little bit better in Boston. I'm going to go back with a little bit more emphasis to try to do that in our city. All right, so enough of me. Okay. Oh, okay. How many more do we have?
Is it working? All right. So I always hate deadening silences. So I can just start and say something at first. I can't even see the panel questions, so I didn't realize there were. So that makes it easier.
I'm gonna pose them to you. So but I'll let you start, Carol.
So what I'm going to say is just it's the beauty of all of us in New York truly is, and this is what Devin alluded to, we all collaborate. This all came to fruition really during the pandemic, where we were calling each other almost every day with plans. I'll never forget the first calls with Shivani, like, what's going on here? And then what's going on with steroids? And then contacting Ruth to find out what was going on upstate, starting CGM, inpatient, all of that. Everything started in New York. And the only reason that things went as well as they did, and they didn't go great, was because all of us were like on speed dial with each other and really communicating. And that, I think, really says a lot about all the issues with academia, institutions, competition. Everyone here still works as a team. And I just wanted to open with that because I think it's something really important and I'm really proud of, and I know we all are.
Great, thanks. Can you guys see? Can you see them down there? Yeah, all right, okay. So I think first thing is, for people who don't know, maybe let's just go across and introduce you all to everybody. And so start with you, Lauren.
Sure, I'm Lauren Golden from the Adult NYU team.
Carol Levy, I forgot to introduce myself. Mount Sinai, New York City.
Shivani Agarwal. I'm the Albert Einstein College of Medicine Montefiore Medical Center site PI in the Bronx.
And Ruth Weinstock, SUNY Upstate Medical University in Syracuse, New York.
All adult endocrinologists, which is cool. There's a whole bunch more of us than we used to be. Okay, so my first question, which is you can speak for as long as you'd like on this, is what makes your clinics unique? Specifically, I know there's a lot of similarities and commonalities, but I want you to try to think about what makes each center unique from your perspective.
I can go. I think ours is pretty obvious. So being in the Bronx, which is one of the poorest counties in the US and New York for sure, we have the most underserved population with diabetes in general, and a huge, very, very large population of type 1 diabetes. And so we do really have to care for people with type 1 with a lot of social determinants of health. We have to think about insulin shortages, Medicaid lapses, underinsurance, things like that, that really do actually affect day-to-day lives. And we have a lot of services, but I can talk about that more. We have community health worker services. We have a lot of community outreach services. We have housing that's part of Montefiore. So we have a lot of extra services that I think are unique for Montefiore.
So what I like to say about Mount Sinai is we try incredibly hard. do a lot of work in diabetes and technology, which has been a passion of our entire group for quite a while. We have specific free educational classes, which I'm sure many of the other sites do too, for patients that happen twice a month, no cost, nothing. We have a large as well underserved community that we really strive for. And we've really had the fortune of being on the cutting edge for a lot of trials related to technology. We will start patients on technology who are more fearful, who are afraid. We've had a lot of experience in a lot of these pivotal clinical trials. So we really know sort of the tricks, the ways to work around and all those things, because we lived through it. It doesn't mean that people who haven't don't have the skill set, but we feel really proud of our background and where we've come from. We have an amazing team of physicians with limited resources on the adult side. The thing I always like to talk about, which I really think is amazing, is anytime someone is going on vacation, you have to ask for coverage. Nobody ever wants to cover anyone when they're on vacation. Within about 5 minutes, we have 8 people agreeing to cover for long vacations for everyone. It's just that type of collaborative nature of a team that I really love and I'm proud of at Mount Sinai. I don't know that it makes us unique, but I think it really attests to the strength of our group.
So I think I'm the newer kid on the block for this group. This is actually my first one of these meetings, which is sort of exciting. So we joined the diabetes program at the adult diabetes program in NYU began just about 5 years ago. And they decided that we really needed to bring a diabetes presence to what was already an outstanding adult endocrine practice, a faculty practice. I think what was both unique and a challenge was joining a practice under the auspices of an academic institution, but everybody was sort of in private practice under that umbrella. Some people are shaking their heads. Maybe you've experienced that. And there was a lot of support for trying to implement a team approach, but they had never really seen it before. And actually, 2 of the members of the team were there with me from the beginning. And I think can attest to the fact that there was a lot of enthusiasm, but maybe a little trepidation. So both sort of support and we're not sure how this works. Like, what do you mean you work with people who are doing education? And a lot of the programs, and certainly where I had come from, had that already. And so I came from Columbia, Mary Pat and Janice and I, we were all there together. So there was really a lot of support, but there was a lot of reinforcement of what I would just say was like basic structural things, that there's not so much hierarchy, breaking that down. And I think we've been able to do that. I think our challenges as an adult site, as Carol mentioned, is not that our patients don't have resources. Our patients actually predominantly are insured. Most of the uninsured patients are at Bellevue, which is a city hospital affiliated with us that has wonderful programs and resources. But as a program, we have a lot of support, but no individual resources. And so we don't have access to psychiatry. I can't just hire a therapist. And so there's a lot of research that goes on. There's a lot of wonderful colleagues and clinical support, but it's shared and it's not unique to us. So we've been trying to sort of wend our way through that. I think we've done a lot. I think there's still a lot more to do. And I always bring back things from the virtual meetings from here I've attended to say, okay, how can we do more with less dedicated resources? But we did come into an infrastructure where there's a lot of research related to diabetes and vascular disease in a very rich research environment. And so we've now built a clinical program within that. And I think this year, coming out of crisis pandemic mode for a few years, we're really just hoping to grow now and do more programming specifically for the patients, which did get put on hold. So I think that's what's coming for future.
So I'm from Syracuse, New York. I work in Syracuse, New York. Actually, I'm originally from New York City, but past umpteen decades have been in Syracuse. So our center is different in that we are about an hour from Canada. For those of you who are unfamiliar with New York State geography, those of us who came from Syracuse, we drove 3.5 hours to the train station and then had a 2-hour Amtrak ride to get here. So we're not exactly next door, just to give you a sense of the geography. We cover over 20 counties. We're the only diabetes center in our entire region. And between us and the Canadian border, which we cover, there's the Adirondack Mountains. There's basically no public transportation, unlike New York City. So there are different challenges that we take care of. A lot of rural poor people, farmers, they're migrant workers. The demographics are different than here in New York City. In Syracuse, we're a medium-sized city. We have the embarrassing distinction of being one of the poorest middle-sized cities in the US, and which is something that there's a lot of poverty in upstate New York. We do have, we're a sanctuary city. So given the size of our city, we do have a lot of refugees. About 1% of refugees who settle in the United States settle in Syracuse, which, you know, considering how small we are, that's actually relatively large percentage of our population. And we have a team approach. So we started our diabetes center in 1994-95. And at that time, we got rid of the old diabetes clinics and the private practices, and we basically started one center. So since 1995, everybody is taken care of in one place and treated the same, whether they have insurance or not. It's all one center. We don't have separate private practice and separate clinics that some places have. And our center takes care of diabetes and endocrine, of course. The other thing that I think is unique about our center is that our pediatric and adult group work very closely together. So until this past June, we actually shared a building and shared resources in that building. Now the institution, that was leased space, built a new ambulatory care building. It's actually a wellness institute. We have the whole 5th floor with pediatrics on one side, adult on the other. But again, we share resources. So for example, the pediatric social worker is out, the adult social worker will cover whatever, you know, share dietitians. We share resources. We feel very close to our pediatric colleagues. We collaborate with them both clinically and also conferences and also with clinical trials. So like when we're involved in some of the same clinical trials as my colleagues here, and we have pediatric endocrinologists supervising the kids and adults supervising the adults. So our team is on the adult side is adult endocrinologists. We have a number of nurse practitioners and physician assistants, nurse educators, not enough, dietitians, a full-time pharmacist, a full-time podiatrist, a social worker. We just last week in this new building, we now have a food pantry on the 1st floor, which we're really excited about. So people who say that they don't have enough to eat that day or the next few days, we can send them home with food. And we're really excited about that new addition. There's a pharmacy on the 1st floor that is affiliated with our institution. And we work closely. Again, we have a pharmacist for people who need patient assistance who can't afford their medications. They give it to them at as low a price as they can. And then we also have, thanks to some wonderful donors, we have a fund that if they can't afford the difference, we can take care of that. So nobody goes without insulin, for example, that we know of. So, and we just, for the first time this month, we just hired a psychologist. This is something we've wanted for the past 25 years. We finally got it. This building has integrated care. I think, you know, the collaborative has really helped us a lot because we started doing depression screening in the very beginning. That was one of the first QI projects. So we showed a lot about people who are depressed and social determinants of health. We've just shown a need, and it's really exciting. So one of our challenges now is how best to use this psychologist. So there are about 200 patients or so who come through our center every day. So it's a constant, working out workflows. We are affiliated with the Joslin Diabetes Center in Boston, which is something a little different, and have been since the beginning. But it's our faculty group practices where we train our fellows and students. And we also are part of SUNY. So that's the State University of New York. For those who may not be familiar with New York State supports 4 medical schools, one in Buffalo, one in Stony Brook, which is Long Island, one in Brooklyn, downstate, and us upstate. So I think that, and just one other thing, because of our geography, we started doing telemedicine over 20 years before the pandemic. But now, because of geography, so I suspect, I don't know if this is really true, my colleagues can tell me, that we do a little more hybrid now than perhaps some other places. So for example, I was seeing patients the other day, and we schedule them all in person now, but one was from like Placid, which is about a 4-hour drive to Syracuse, and one was from Ogdensburg, which is near the Canadian border. And they had a snowstorm that weekend, that morning, the first snowstorm of the year. So and one is 77 years old, and I really didn't want him to drive. The other was in her late 60s. So we flipped it to telemedicine. So instead of doing an in-person visit, since we can still get reimbursed, and they were both using hybrid closed loop and I could see their data, I was able to do telemedicine. So we're still doing that. If people have trouble getting to us, again, transportation is an issue for us, or for other reasons, there are lots of reasons why people can't get in, even if they live a few blocks away. We are still doing some telemedicine. And I guess I've talked too long, so I'll stop there.
Oh, thank you very much. That was great. So I think talking about the geography, I think I'm interested in how collaboration works amongst your teams and areas and that may be research collaborations, QI collaborations. I think this is what we're all here learning about, collaborating together. And so I think you've got some cool stories that you can most probably tell us about successes, failures, things that you've learned from each other, and ways that you leverage the geography to the benefit of your patients and to the benefit of your clinical or research programs. So maybe Lauren, we'll start with you.
Sure. So, I want to echo what Carol said. And when we met to talk about this early on, and Shivani, we missed you, it occurred to me that I have actually personally worked with every single person here, which I think, again, New York, the endocrine world is small, but I was your attending, you were my attending, and we lectured together in Austria. So, I think to begin with, there's actually personal relationships underneath just our working relationships. And there's really no ego with any of us. And so I guess what I would say is either an email or a text or a phone message is what starts it generally. And within seconds, everybody's on board. I'll give an example and you can talk about some of the pandemic stuff, but outside of that, Carol was recruiting for a study using technology in pregnant women with type 1. And our patients have been clamoring for, when are we going to have a closed loop system that's actually approved for that use? So every next patient of mine who was pregnant or thinking about pregnancy for the next few months, I just kept saying, there's this study going on up at Mount Sinai, because we're not doing it. We're not set up to do it. Within the city, we have an expert who's doing it. And it's better for all of us for me to send them to Carol and get that study done. And so we had a great little collaboration. I would reach out to Carol and the coordinators and Granny, right? So all of these folks, and that's always in our mind, that if someone can get it done, who's doing it and doing it the right way and a leader in the field, we should just help get it done. And then we should move on to the next project. And I feel like we have gotten a lot done that way. Maybe I'll let you speak to what was going on during the pandemic when we didn't know what to do, but.
Pandemic brings back wonderful memories. That's why I'm still wearing a mask. So yeah, with the pandemic, it really started, as I already alluded to, with nurses. There were no nurses available. We have no idea what's going on with our patients. I remember when Shivani and I were texting, they started steroids. What's with this steroid thing? And we had no finger sticks. So that was when we actually reached out, believe it or not, to David Panzer and to JDRF and said, we need CGM. How can we get it? And it was a team effort. We were all texting. We were all talking. It was a little more crazy initially in New York City, but I remember later on, Ruth, you and I had discussed some of this as well. But we really got this started. I mean, to talk more about just general collaboration. Transitions of care. We contact Shivani. She gives us guidance. How do you do some study or how do you set up a research program in obstetrics? Someone at Einstein contacted me. We collaborated on that. How do you infuse Tzield? We contacted NYU because they were ahead of us on this. And we're like, are we even bothering to do this when 3 hospitals are competing with each other 20 blocks from each other? I chuckle with what you said, Ruth, about video visits. I have patients who don't want to go 10 blocks, who will do a video visit. So it all becomes very different in terms of perspective on these things. But there's lines of communication. I consider Ruth one of my role models from when I was very junior, and I still do. And I always say,
still my role.
wish I was Ruth Weinstock and how she pulled all this together. But we really collaborate, and this is not fake. This is not just up here for the group. We really do collaborate.
Yeah, I wholeheartedly agree. I kind of grew up under these amazing women, and I'm lucky to really be on the stage with them now. I will say, even from a care perspective, sometimes, there's a patient that's moving from the Bronx, let's say, to Manhattan. So I'll call, Carol or Lauren, or if There was one time, I think I was working with Grenia, she must be here somewhere,
I'm sure she is.
where there was a DME that was being really difficult with for our patients. We were like, you know what, let's both get on the phone with them and say that we will not prescribe to them until they make it easy for us, so then we had like Sinai's power and we had Montefiore's power. And so there are really actually intricate ways that I think we interact with. We don't even realize it, but we do think of ourselves kind of as a force. We're not competing. We have our own thing. We have our own catchment area, but also interact in many ways, I think.
There are enough people with type 1 diabetes,
Yeah.
unfortunately, that we don't need to compete at this point.
I mean, I just feel we're so lucky in New York to have such dedicated people and such wonderful teams. And I really value all of these collaborations. I think one thing that we all struggle with is access. None of us have enough endocrinologists or providers to take care of everybody who wants our services, and we brainstorm about that. I mean, being in the same state, I mean, one thing that we certainly collaborate and could collaborate more on probably is on advocacy in terms of New York State and what Medicaid covers, because there are some state specific issues that, and we all have a lot of Medicaid patients. So that certainly is something, but we have collaborated on actually formally, we're involved in some of the same clinical trials, and informally, I think that we all feel comfortable talking to each other. I learned from Shivani about her transition program, and I've learned from Carol. I mean, we all learn from each other, and I think that's and we all learn from all of you. I think that this learning network has just been fantastic. I mean, I remember when it started, and just I know that our center is so much better now because of our participation in this collaborative, and our the way that we have now structured QI, which was not well structured when we started. So I don't know if someone here from the Helmsley Charitable Trust, but thank you. And also thank all of you, because we do learn from all of you as well.
I wanted to say also, it does cross lines. Like I'm looking at you, Mary Pat, like pediatrics also, like we really do learn all together. We get on the phone. It's just easier. So yeah. I feel like we're talking too much. Do people want to answer?
No, this is perfect. This is exactly what I wanted. So just linking on to what Ruth mentioned around kind of state advocacy and kind of local politics, maybe just let the other three just weigh in on that, because, for those of us who don't know New York State, how that's unique and how that plays into what strengths that you potentially have and what are the challenges that you have that are unique to working in New York State. So maybe
I'll just take the Medicaid
please do.
part. Okay.
Yeah.
So we have to be specialists in Medicaid at Montefiore. We just have to. We know all of the managed Medicaid plans. Health First is one of the largest managed Medicaid insurers in our medical center. So it's like they insure probably 65% from Health First Medicaid, but then we just ran these numbers actually, Owen, right? I don't remember, maybe 30-40% Medicaid, but then Health First Medicare is the other part. So that's a dual kind of Medicare, Medicaid. So you have to know the policies inside and out. I will say that the Medicaid policies are quite generous for diabetes technology. They cover every single CGM that ever comes out, which is really good. They cover all the hybrid closed loop therapies. It's just, you just have to jump through some hoops to get there. So you have to do prior authorization procedures. Really interestingly, the managed Medicaid programs, I don't remember off the top of my head, but there were something like over 200 New York managed Medicaid programs, or something like that. And before April of this year, each managed Medicaid program had a different prior auth procedure, had different paperwork. It was nuts.
Different insulin
formulas, et cetera. It was totally nuts, and I think that really hampered patient care, because if you don't know what to prescribe your patients, the pharmacist can't just change it out and then they don't have their insulin, right? So it was really dangerous. So what Medicaid did was they made the New York RX Medicaid program. So they kind of brought all of the pharmacy prescriptions under one umbrella. So there's still the managed Medicaid insurances, but one pharmacy program. So we know we go to one formulary, we know what CGM, what insulin, what glucagon, whatever is covered. And the prior auth procedures, I think they've made it much easier. So since April that enacted, and I think it's just so much easier to get everything for our patients. Medicare, slightly different story. I'll let other people talk to that. And then the only other thing I will say is, I'm forgetting right now. Okay, I'll come back to that. Oh, sorry.
Yeah.
The prior authorization procedures. So it used to be for some insurances, every 3 months, you had to reauthorize CGM, which was a nightmare because what that means is you have to have a physician order, you have to have a certificate of medical necessity. This is all paperwork. And then you have to send chart notes, but you have to actually prove that you're seeing your patient within the last 3 months. So that's really hard, right? So people were dropping CGMs left and right because we couldn't reauthorize it. They moved it. We at Montefiore had advocated for at least Health First to do every 6 months instead. And so we actually did a demonstration project with them to show them what the impact of a 3-month prior auth versus a 6-month prior auth did. And it was a huge difference. They had no idea. They were like, oh, it's just paperwork. It's not that hard. It's fine. You know, we're like, this actually is affecting patients' lives. Like there were less hospitalizations with the 6-month authorizations, you know, et cetera, et cetera. The A1Cs were better. So anyway, so that was one little kind of advocacy thing that we did internally, but I think we could have done as a group if we needed to.
So jumping off the Medicaid piece, the other challenge that comes up sometimes that we really struggled with, and I don't think I have an answer yet, is when people transition from one insurance to another. They either go from commercial insurance to Medicaid or vice versa. And once again, they lose all these great resources and all of a sudden they have a job and then all of a sudden they have crappy insurance. And these become real struggles where we have to get creative with this and really think about ways to best support our patients. I don't have any of those answers now. The other piece that Ruth touched on, which is an interesting scenario, and I don't know if it's true of both of your institutions. I know it is at Bellevue because you're of different posture, but it's somewhat, I hate to say it, of a 2-tiered system that we've worked really hard on. There's a Medicaid clinic, and then there's a faculty practice. I don't even know if that's true anymore at Einstein.
We've never, yeah, we don't have that. All our
You're
faculty
lucky.
take all plans. So we have every fellow and faculty will see the same mix of patients.
Which has been a huge frustration within the greater New York City, Manhattan area, where we do still struggle with this piece. And it's resources, it's Article 28. There's a whole bunch of million things that go into all of this that I am not smart enough to fully understand. But although we've done everything in our power at this point, and we've done a lot, and I really want to thank Grenia, wherever she is, to really push forward to make things relatively equal in both clinics. They're separate, but at least now they're relatively equal. And this has been a struggle. And we both deal with this a lot. Yeah.
Yeah, sure. I think as part of a network that has a city hospital, so the majority of the under or uninsured patients are at Bellevue. There are certainly Medicaid patients in our clinic. One of the things, but linking those two clinics, it's almost like those are two different worlds. Those are two different hospital systems within the same network. They happen to have a fabulous clinic over there, which is great, and actually a lot more services for a lot of things than we do. We have to get permission for some of the Medicaid plans on a case-by-case basis to take those patients. And the irony of this is not because we're not all enrolled in those insurances. It's because I believe it's Health First has a requirement that for a new patient visit, it has to be within 48 hours of the request or 72 hours. It's a very tight window, and we don't have enough. We can't guarantee that. We cannot guarantee that every person who requests an appointment, urgent or not, can be seen within this very tight window that they specify. So the workaround is that we're all enrolled in those plans. Anyone who already is on those plans can be seen by us. But to have a new patient to the practice come in, I have to get permission. Now, the permission is always granted. I just go to the division administrator. I want to bring this person over. They were new onset type 1. They were just discharged from the hospital. I'm not sending them somewhere else. I already know them. And the answer is yes, that's fine. But we can't officially be enrolled as a new Health First site for that specific reason. It occurs to me, maybe we should all discuss that. If
yeah, we should discuss that. I don't think we do that.
And maybe there's a way, to get around that and maybe use some advocacy. So
Have some tips in place that we use to get around that.
right. So we just asked for permission, but it'd be great to actually not have to kind of sneak in the back door because we're happy to see those patients. Separately, my more successful venture at getting some of those patients over is if they were at Bellevue to begin with, and they've already seen the fellows, but the fellows rotate with me once a week. They sort of show up on my clinic day. And we just get permission for that. They're already known to the fellow. It's continuity of care, but maybe we have more education resources because we have our team. So I think that's, in the New York landscape, that's sort of a problematic thing, and it's a changing target every time I look into it. I think from the standpoint of prior authorizations, we're very fortunate in one way that I think because NYU, and I'm sure all of you, were getting just bombarded with prior auths for every medication, right, that you prescribe. And because we're not a dedicated only type 1 clinic, we have a lot of, the majority is type 2 patients. So the office actually couldn't keep up with the prior auths, mostly for the GLP-1s and all of the other things that we're doing. And so the institution actually hired additional pharmacy staff to be a prior authorization team. The thing that they don't do is all the type 1 stuff. They don't do insulin, they don't do technology, they don't do anything related to that piece. But because they have offloaded the office staff from having to do that piece, our office staff actually now can focus on the insulin and the type 1, the type 1, the technology. So I think from the standpoint of maybe what we could all do, this is such a disproportionate burden that's being placed on all the practices. I mean, everybody knows this, right? We all have this. And it's being driven obviously by insurance companies and other things beyond our control, but we almost can't keep up sometime. And I think to everybody's point, then people go without insulin, then they go without their sensors. They come into the office hypoglycemic, kind of dragging themselves in just to get to a visit because we have some samples. And that's a tragedy. Like, we really have to be able to do better than that. So I feel like both from the New York standpoint, but I think the advocacy of this group, I'm game to put some effort back into it. I don't know which parts of that are movable, like which parts we can actually impact, but it would be nice to work together on it. None.
I mean, having done that work from 3 to
Yeah.
6 month prior auths, it's actually quite movable, I think.
Yeah.
I just think we all have to figure out the right language to speak to payers, because I think some of it makes sense and some of it just doesn't. And I'm not sure that they totally understand the implications of what seems like an administrative move, So it just takes the right language and conversation, but.
Yeah, well, let's not reinvent it then. Let's
Yeah.
nail it down and do it.
Yeah.
So we are fortunate in that our outpatient pharmacy has taken over getting the pre-auth for us for medications, but not the technology. And technology is really difficult. So in upstate New York, even though we're all the same Medicaid, our managed care plans and our Blue Cross Blue Shield, et cetera, are different than the ones in downstate. So there are some differences there, but we actually had to hire a full-time person just to take care of the technology orders, for which fortunately we were able to get institutional support for that. But we have a full-time person who just helps get the sensors and pumps, et cetera, approved. And the insurance companies, still require faxes sometimes. I mean, they won't take an electronic order, it's back and forth 3 times. So that it's not a great solution, but it hopefully will help us get people what they need. But I wish we could have the insurance companies pay for this person and their fringe benefits, because it's
So I have a question for you, Ruth, about justifying that prior auth for this technology piece. What I keep entertaining, because we have the same headache here, and I'm sure other sites do too. I'd love to get that prior authorization person. Did you go back to the institution and say, look at all the money that we can bill for CGM? And that was how you were able to get the justification for it?
well, we do bill for CGM, but I have to say that we have a fantastic administrator, Beth Wells, right over there. Beth, you're the one who got us this position. She advocated for us with hospital administration, and I don't know if you want to give any tips, Beth, on what you did for that, but we're very fortunate that we have an administrator for our pediatric and adult services that's extraordinarily capable, resourceful. And it helps us. She helped us, get pharmacy to do some of the pre-auths for the meds. And I know maybe people are interested could talk to her afterwards on how she got the institution to pay for this.
We came up with kind of a creative way to do this, because our institution wouldn't have paid for it just for endocrine, but we have a full-time technology authorization person as well. But they are actually borrowed from primary care. So we have a very large federally qualified network of, it's kind of complicated, but federally qualified health centers, primary care, internal medicine, and family medicine clinics that service millions of people in the Bronx. And they have a lot of resources because they're an ACO, right? So they're an accountable care organization. So they have all this extra staff to do this stuff. And because we have such a large type 2 population that is serviced by us in endocrine, like over 2,500 type 2s, and primary care wants us to do CGM for their type 2s, they gave us a full-time person to do that. And then we said, okay, well, we're also going to do it for our type 1s. We're also going to do all the prior auths for our type 1s with this person. So there's some like interesting ways that, you know, you don't have to spend money in endocrinology to use money.
Oh, great. This was fantastic. I think we've got 3 minutes left.
So we would love questions from the audience. So we have microphones. If people have questions for this group, we'd love to give you the opportunity to ask them now.
Do we still have the 3 minutes or they got more time?
More time. We have 10 minutes for questions.
10 minutes for questions from the audience. Okay, so fire away. Put up your hand. We'll get you a microphone if anybody's got any questions. And then here we go.
Good morning. I'm Marissa. I'm from Cincinnati Children's and Children with Diabetes. And I love this idea of sort of coming together and telling the insurers to, I don't know, something that I'm not going to say in this microphone, and, but banding together with, I mean, we would have to do it because of the way that endocrinology is. And thank you all for working in endocrinology. I know you don't get paid as much. I know we don't bill as much, but what if we did something with like the American Academy of Pediatrics, the American Medical Association, to talk about how much of a time suck and a resource suck all of this PA work is?
Full disclosure here, in 2021, I was president of Medicine and Science of the American Diabetes Association. So I can tell you that there's a very strong advocacy group at ADA that is fighting and has fought very hard for affordable insulin, for example, but also on all of these issues. And they're continuing to do that. It's a totally voluntary organization, and we are working on the federal level for that, but it's a continuous, and ADA isn't alone. Endocrine Society is, and a lot of other organizations. So this is something that ACP as well, that people are advocating for, through their professional organizations. And I'm sure there are people advocating it from in other ways.
Yeah, I've had the fortune, I think several of you in the audience are part of this, of really fighting with Medicare about basal only use for people with type 2. I know we're a type 1 group, but the adult side, we see a lot of type 2s. And I mean, just working with like Earl Hirsch, Janet McGill, like, boy, is Janet, you don't want to get in a fight with Janet ever. But we were able to push through. I was a small little piece of it, but we were able to push that through. And then CGM for pregnancy, we were also able to push through, which I think was huge. So there are places to really move things forward through advocacy, presenting data, and really showing outcomes. The other piece that I think I'm going to throw out 2 things to the group, because I'd love to hear some of your answers, are access, which Lauren alluded to, is a disaster everywhere. And the tips that maybe some of our sites are using, we have a tricky way that we can get people in quicker right now. I'm not sure it's really benefiting us, but it's something the institution required. So now we can get people in quickly. And then the second piece, which Shivani alluded to, is how do we get our colleagues who are not endocrinologists to get better at CGM analysis? We have actually trained our obstetricians now in how to interpret CGM, which has been huge for pregnancy. But this is a huge area too, where we have to expand our knowledge, because there are only so many of us and we are not growing. So I don't have an answer to any of those, but if anyone else has any thoughts, I'd love them. Nothing.
One over here.
Yes.
So no, I don't think none of us have an easy answer. Peds endo pipeline is probably even worse than adult. I think we're all struggling, and I can probably speak for most of the peds endos in the group here. We've gone to lean on advanced practitioners for taking maybe 60 to 75% of the normal clinical visits and follow-ups, because they don't do as much endo patients. We recently, just to get more closed loops and pumps on, have actually reached out to our diabetes educators and trained them to actually put those on in while we sign for the dosing and everything. So that's one of the ways to kind of get around things.
I would say while you're getting there, we do rely heavily on the trainers from the companies. We don't have staff to be able to do full-time trainings. They take too long, and our institution says you can't bill enough for that for the hour and a half that they do. So we heavily rely on our trainers, but we train the trainers.
Yeah.
And then we say we can only have like 1 or 2 trainers per company. And they work with us, and I watch them and I tell them, this is the kind of stuff you need to say, and this is what's important to our patient population. So that's one way.
I just want to say one thing that we do the same thing, but in terms of training, and so I have been in recent years been focusing on older adults with type 1 diabetes. And when you train an older adult with type 1 diabetes, an hour and a half is not enough. We have there's a lot of time, and the insurance companies, including Medicaid, don't pay for enough hours.
Right.
For training and also for transitions. When the older adult now needs a caregiver to take over some of the tasks, you have to train the caregiver. There's a lot of time that is spent not just in the initial, but in follow-up. And we really need to advocate for more education time from Medicaid and Medicare, because they limit the number of hours they will pay for each year, which we know from studies that we've done and we're doing now that older adults benefit from hybrid closed loops, but they need more time and training.
So, sorry, that's really loud. I'm Joy from Seattle Children's. I was just going to comment on the training piece. We also have our nurses do our dose adjustments and rely heavily on our nurse practitioners to see our diabetes patients, which helps with overall access. And then for the DME piece, we also have a full-time DME coordinator, and I wish everybody all of the luck in the world trying to get help with that. The PA piece is really challenging because every state is different and every state has different rules. And so what works in New York isn't necessarily going to work in Washington State. And I think that's where national advocacy really needs to work. It needs to get on a national level. The PA system just needs to stop. It's horrible for patient outcomes. That's really where I was going.
Hi, that's Matthew Dacus from Johns Hopkins. First of all, thank you so much for sharing your perspective. It's really amazing how much collaboration you guys have had within one city, and there's no sense of competition or anything. I'm wondering to what extent you think that collaboration was driven by the fact that you all know each other and train together? That's one part. And then the second is, are you all on the same EMR systems? And if not, how did that affect sharing of best practices?
Well, I can start by saying I'm the only one who actually, I think, trained with everybody or worked with everybody, although you guys could correct me. We were in a cop car together during a blizzard, so I'll never forget that. We'll tell that story another time. But
I think I blocked that out.
Yeah. We were escorted by COP as essential personnel. That was an exciting day. But yeah, I do think it's partly, we're all human beings here, and we all, as much as this is one city, I think we're a microcosm of this entire group, which is we have different little universes within the city. So I think that came naturally to us because we can't do everything ourselves. There's just not sort of enough of us.
And I would say inevitably there's so much, like, people move institutions, they do training in one, they move, then they get another job. I mean, we all have to kind of play nice too, because inevitably we're all mixing, so.
And there, none of us can meet the demand.
Yeah.
So our hospital leaders may feel they're in competition with the other hospitals, but we are in the trenches.
Yeah.
And, we all have, way more to do than there are hours in the day. And so, the best way is to collaborate and figure out how best to fulfill people's needs. And I can tell you in upstate New York, we're just losing endocrinologists left and right. The other major hospital in our city just lost their endocrinologist. Now we're supposed to take all those patients, and we're already getting over 120 new patient requests a week, and we lost someone and everyone's schedule is full. So how to accommodate these kinds of volumes, is challenging, to say the least. And certainly I don't feel in competition. Someone moves to New York City. Great. I know these wonderful diabetes centers where you'll get great care.
Exactly.
Carol, before you go on, we're gonna have to end the session.
Okay.
So we don't.
I'll just
Go
say,
for it.
I think we're all on Epic. Ruth, are you on Epic or you?
Yeah.
Okay.
Yeah.
So we are actually all are on Epic.
But they don't communicate.
Yeah.
So like, we're still our own islands of Epic.
Yeah,
you
but
know?
we
Oh,
can
care
see each
everywhere. We have
other's-
care
yeah.
everywhere.
We can see each other's Epic, which helps a lot. And I know we're out of time. I'm going to say one more thing. We don't compete, but we leverage the competition between institutions.
Yes.
And we say, well, they're doing that at Einstein. So if you don't let us do it, we want to do it. Or they're doing it at NYU, you better let us do it. So that actually works very effectively.
All right. Thank you very much. That was great. Appreciate it.